Okay, well, thank you very much. I want to thank the organizers for the invitation to speak in this session. It's really my pleasure to be here. Wish any mothers out there a happy U.S. Mother's Day. It's Mother's Day today. I'll be talking about evidence-based best acquisition protocols for clinical DSC. I'll be focusing on neuro-oncology applications. So we've been doing DSC-MRI in the brain since the early 90s, including the first fMRI of visual stimulation and the first MRI-based CBV maps in gliomas. And since then, the technique has had multiple clinical applications, particularly in neuro-oncology, including tumor grading, biopsy guidance, and treatment response assessment. We're still really debating the best way to perform this technique, primarily because there are multiple protocol decisions to be made for single echo gadolinium-based DSC, including the choice of pulse sequence, preload and bolus contrast agent dosing, image acquisition parameters, including flip angle and TE, and post-processing techniques, including post-processing leakage correction. And so after briefly reviewing DSC MRI fundamentals and contrast mechanism, including the problem of contrast agent extravasation and leakage correction, I'll present evidence supporting the best acquisition protocols for clinical DSC, and I'll summarize current DSC protocol recommendations by a national consensus panel and discuss further steps toward its validation and broader acceptance. So as far as evidence is concerned, I'll provide DSC theory, modeling and simulation, stereotactic tissue correlation, and some clinical data. For best clinical practice, I'll emphasize cerebral blood volume, or CBV, accuracy and precision in neuro-oncology applications, including suitability for multi-site clinical trials. And for DSC, we'll be focusing on single echo gadolinium-based technique because this is the most common methodology in practice. And I hope to leave you with appreciation for a clinically practical DSC paradigm that affords high accuracy and precision. Okay, so let's begin. DSC-MRI mimics indicator dilution technique, where flow and volume in organ systems is determined from a known quantity of injected tracer and measurement of output concentration. And DSC-MRI applies this technique to the brain. Our tracer is gadolinium, and we acquire most commonly echoplanar imaging dynamically at baseline and during passage of contrast agent through the brain, which yields transient signal loss due to magnetic susceptibility effect. And if you put an ROI in tumor versus normal appearing white matter, you get very different signal versus time curves. But we need concentration versus time to apply tracer kinetics. So we convert signal versus time curves to relaxivity versus time curves, assuming that signal change is due purely to change in T2 relaxivity, which is directly proportional to contrast agent concentration. And by applying tracer kinetic principles, you can show that relative cerebral blood volume is proportional to the area under the relaxivity versus time curve. So there are two requirements for this methodology to work. The first is that there's a linear relationship between the change in relaxivity and concentration of contrast agent. And this motivates an understanding of the underlying DSC-MRI contrast mechanism. Intravascular contrast agent creates a susceptibility difference between the intra and extravascular space, and this creates magnetic field gradients that depend upon the susceptibility difference delta chi, the size of the vessel r, and distance from the vessel. And as protons diffuse through these spatially variant magnetic field gradients, they lose phase coherence, leading to signal loss. This behavior can be solved analytically for some limiting regimes, but in vivo, it's best approached using Monte Carlo methodology that simulates the relationship between relaxivity and physiological parameters of interest, including vessel size, diffusion rate, and contrast concentration. And these simulations have yielded the well-described vessel size dependence for gradient echo and spin echo relaxivity. We know that gradient echo plateaus for large vessel sizes, whereas spin echo relaxivity peaks for capillary-sized vessels. And these are fundamental relationships that are qualitatively independent of vessel geometry. There are important clinical implications for the size dependence relationships. Because spin echo relaxivity peaks for capillary-sized vessels, Spin echo DSC may be more appropriate for stroke imaging, where we care about capillary level perfusion deficits, and we also seek to minimize susceptibility artifact at cortex-sulcal interfaces along the convexities. Gradient echo is more sensitive to the enlarged, disorganized microvessels that are a hallmark of high-grade gliomas, and so gradient echo DSC may be more appropriate for tumor imaging. It can also be shown from basic principles that the relaxivity change is directly proportional to contrast agent concentration, which is required for tracer kinetic theory, only where the size dependence curves have plateaued. And so this is where, for instance, doubling contrast agent concentration will yield twice the relaxivity. And this behavior occurs over a much broader range for gradient echo compared to spin echo acquisitions, and that's why gradient echo CBV estimates are inherently more accurate than spin echo CBV estimates. It can also be shown that the x-axis of the size dependence curves actually scales like vessel size squared divided by diffusion. And so as diffusion rate decreases, like in restricted diffusion in densely cellular tumors, for instance, you move to the right along this curve, and this can either increase or decrease relaxivity for spin echo, with much less variability for gradient echo because of the plateau. And this also has important clinical implications. So when we have brain tumors that have heterogeneous diffusion coefficients, if you see hyperintense signal on a cerebral blood volume map, that can imply either true increased blood volume, which is the desired relationship, or it could imply some degree of restricted diffusion, which would be considered artifactual. And the uncertainty is much less for gradient echo because of that plateau. So it also turns out that these size dependence curves shift up and to the left with increasing field strength and contrast agent concentration, broadening the extent of the plateau. And so gradient echo acquisitions at high field strength made with high relaxivity contrast agents all theoretically improve the accuracy of DSC-MRI and are therefore desirable in clinical practice. The second requirement for DSC to mimic tracer kinetics is that the contrast agent must remain intravascular, and this is clearly violated for contrast-enhancing or high-grade tumors. In such case, with contrast agent extravasation, there is a susceptibility difference not only between the intravascular and the extravascular space, but also between cells and the extracellular space. And so DSC signal is affected not only by the vascular volume fraction, but also by the cell volume fraction and vascular permeability. And in this case, the relaxivity versus time curves no longer return to baseline like they do in classic tracer kinetics, but they'll extend below or stay above the baseline depending upon whether T1 or T2 star effects predominate. And so clearly the relative cerebral blood volume estimates, which are proportional to the area under the relaxivity time curve, will be impacted. Now we have several techniques for reducing contrast agent leakage effects. These include the introduction of a contrast agent loading dose or preload, which is an injection of contrast agent prior to the main dynamic bolus. Pulse sequences that reduce T1 sensitivity, including low flip angle and long TE, as well as post-processing techniques, including model-based leakage correction. And much of the debate about best DSC practice centers upon these issues. Intravascular contrast agents like ferumoxytol eliminate contrast agent leakage effects entirely, and they yield cerebral blood volume values that are very consistent across multiple contrast agent injections, whereas gadolinium-based CBV tends to vary and be preload dose dependent, and this can impact longitudinal measurements in clinical trials and yield intersite variability. There are several NCI-funded trials that use ferumoxytol-based CBV, and proponents of this technique are very bullish on its application, although I might contend that its clinical application might be somewhat limited because the standardized brain tumor imaging protocol, or BTIP, which is a consensus-derived standardized methodology for performing conventional imaging in brain tumors, and is gaining traction at local sites and in multi-center trials, requires that post-contrast imaging be done after one total dose of gadolinium-based contrast agent. And so I'm going to focus our discussion on DSC on gadolinium-based methodologies. So preload contrast dose administration before the main bolus shortens the extravascular T1, and it establishes a new baseline after the preload injection that reduces relative T1 effects during the second dynamic bolus compared to after the preload. And Leland Hugh determined that a preload administration of 0.1 millimole per kilogram given 6 minutes prior to the dynamic bolus maximizes CBV differences between tumor and post-treatment related enhancement in high-grade gliomas with recurrent enhancement. And so this preload dosing protocol has been adopted by multiple local sites as well as some clinical trials. Model-based post-processing leakage correction uses linear fits of measured relaxivity to functions of average relaxivity in non-enhancing brain, one of which is permeability weighted, to correct for both T1 and T2 star leakage effects in each voxel. And this is a technique that has found its way into several commercial software packages. Now, it turns out that preload and model-based leakage correction are synergistic. They're often used in tandem, especially for high flip angle acquisitions. And so CBV made using preload as well as leakage correction correlates strongly with tumor grade, which is expected, whereas uncorrected CBV does not. And in a rat gliosarcoma model, increasing permutations of preload plus post-processing leakage correction yield CBV values that converge to a Myon intravascular contrast agent gold standard with less bias. Now, we also have histologic validation of CBV accuracy using both preload and leakage correction. Stereotactic biopsies co-registered to leakage-corrected cerebral blood volume maps made using a preload, intermediate flip angle, and this model-based leakage correction have shown very good correlation of cerebral blood volume with microvascular area and density. So we've got good tissue correlation. However, it's also the case that stereotactic biopsies co-registered to CBV maps made without any leakage correction, that is, without any preload, using a low flip angle, and without any model-based leakage correction, have also shown good correlation of CBV with microvascular expression. And so there are both high and low flip angle DSC strategies that have some trade-offs. Acquisitions using a low flip angle, a long TE, have decreased T1 sensitivity, which requires less of a preload administration, however might suffer from poorer SNR, whereas higher flip angle acquisitions have a more T1 sensitivity, requiring preload administration to reduce that, but have better SNR. And these trade-offs have led to quite variable DSC methodology found in the literature. And this can lead to conflicting, somewhat confusing results. So Patel performed a meta-analysis of studies using DSC for recurrent high-grade glioma versus post-treatment enhancement. And for the subgroup of studies that used mean lesion CBV as a metric, they found high pooled sensitivity and specificity of CBV for recurrent tumor, but a wide range of optimal CBV thresholds. And this variability is likely due to a wide range of DSC parameters that were used in the literature, including the choice of TE, choice of flip angle, use of preload, and the use of post-processing leakage correction. And these authors concluded that standardization is needed before implementing any particular quantitative perfusion strategy across institutions. And this is very important for the translation of DSC to multi-center trials. Now, there have been multiple efforts at standardization of DSC protocols taken by different organizations, including the American Society of Functional Neuroradiology, which published a white paper based upon common clinical practice patterns. And this advocated the use of a 1/4 to full dose of preload, a full dose bolus, and a 60 to 70 degree flip angle. And I want to now summarize some recent work done by the DSC Standardization Subcommittee of the Jumpstarting Brain Tumor Drug Development Coalition. This is a group that's supported by the National Brain Tumor Society. And we used these ASFNR recommendations as a springboard for an updated consensus DSC protocol. Now, we sought compliance with the standardized brain tumor imaging protocol, which, as I mentioned earlier, requires the post-contrast imaging to be performed after one total dose of gadolinium-based contrast. And again, this protocol is advocated by the National Brain Tumor Society. It's really taking root at multiple sites, and so compliance with BTIP is really deemed essential for any DSC protocol. So therefore, we would either have to give a single dose of contrast split between preload and the DSC bolus done before post-contrast imaging, or you'd have to give a full dose of preload and then do your DSC bolus after the conventional post-contrast imaging. Those are really the choices. And our group took a computational approach for determining optimal BTIP-compliant parameters. Ben Ellingson's group at UCLA performed model-based simulation of DSC signal with contrast agent leakage, and they generated heat maps of CBV error versus theoretical CBV without contrast agent leakage for various acquisition schemes. And the schemes that had particularly high fidelity included the ASFNR parameters with an intermediate flip angle, double dose contrast including full dose preload, but they also found that a low flip angle acquisition without any preload administration worked very well. Chad Quarles's group at Barrow got similar results using a digital reference object matched to glioblastoma training data, and this table compares performance for an intermediate and low flip angle acquisition. So for double dose contrast with a full dose preload, both schemes have excellent accuracy and precision at both 1.5 and 3T. However, for single dose contrast administration without any preload, the intermediate flip angle performs very poorly, but the low flip angle scheme maintains excellent performance at both 1.5 and 3T. And in fact, the low flip angle acquisitions have equal or better performance for all contrast agent dosing schemes. And this may be an attractive strategy in practice. Their simulations show that even without preload, the low flip angle CBV, shown in blue, has excellent accuracy along the line of identity with much less bias compared to the intermediate flip angle CBV, shown in red, particularly at 1.5T. And so this may be an attractive DSC protocol requiring less contrast agent. So we concluded from these analyses that contrast agent dosing matters. Double dose contrast with a full dose preload provides high CBV accuracy and precision, low sensitivity to parameter variations, and may be beneficial in clinical trials. For BTIP compliant single dose contrast administration, the intermediate flip angle performed rather poorly compared to a low flip angle acquisition. The single dose, no preload 30-degree flip angle scheme has theoretical advantages, including reduced contrast agent usage, but potentially poorer signal to noise, and this justified a formal comparison of these techniques. So we performed such a comparison. Kathleen Schminder just recently published the results of a 3-institution prospective trial that enrolled patients with high-grade gliomas or metastases that had at least a cubic centimeter of contrast-enhancing tumor, and 43 patients were enrolled. And in this study, we performed gradient echo DSC using 2 successive full-dose Gatavist injections separated by conventional post-contrast imaging, a 30-degree flip angle DSC without preload, P-, provided preload for a 60-degree flip angle DSC, P+, and we obtained CBV maps without and with leakage correction, yielding 4 permutations of CBV maps. And we're primarily interested in comparing the performance of the low flip angle, no preload acquisition to the intermediate flip angle acquisition with preload. What we found is excellent agreement between the no preload 30-degree acquisition scheme and the preload intermediate flip angle acquisition scheme according to Lin's concordance correlation. And we also found that there was still substantial added value of leakage correction even in the low flip angle, no preload scheme, which putatively has lower T1 sensitivity. And so we concluded from this comparison that a low flip angle, no preload DSC has excellent concordance with an intermediate flip angle full dose preload protocol it requires less contrast agent, fewer contrast agent injections. And we also conclude that post-processing leakage correction is still impactful even for low flip angle acquisitions with less T1 weighting. So our current consensus panel recommendations for a BTIP-compliant single echo DSC scheme would include gradient echo DSC, full dose dynamic bolus with low flip angle, and field strength dependent choice of TE with post-processing leakage correction. Omission of preload gives excellent performance, requires less contrast agent administration, and may be applicable to routine clinical use. Use of a full dose preload may provide higher performance overall. It would permit simultaneous acquisition of DCE and may be applicable to multi-center clinical trials. So I just want to finally just mention a couple trials that are ongoing to test these concepts and to establish the utility of CBV in the clinical setting. So we submitted a primary imaging trial for DSC entitled Multi-Site Validation and Application of a Consensus DSC-MRI Protocol. This is NCI funded at 4 participating sites, and it actually is providing a direct comparison between this low flip angle, no preload scheme and the intermediate flip angle, full dose preload scheme using stereotactic guided biopsies of patients with recurrent glioblastoma on standard therapy. And so we're going to establish the tissue validity of this low flip angle technique and demonstrate its performance in comparison to the thus far reference standard. I also want to mention an ECOG Akron trial that is ongoing. This is EAF 151. It's a primary imaging trial for DSC entitled Change in Relative Cerebral Blood Volume as a Predictive Biomarker for Response to Bevacizumab in Patients with Recurrent Glioblastoma. This is also NCI funded, and it's really the first use of an NBTS consensus DSC protocol in a multi-center trial setting. Here we're using the double dose scheme, in this case with an intermediate flip angle, but this is evaluating the utility of DSC-MRI for predicting outcome in patients on bevacizumab with recurrent GBM. The primary objective is to determine whether binary changes in CBV within enhancing tumor from baseline to just 2 weeks after starting bevacizumab correlate with survival. And it's studies like these, I think, that are important for demonstrating the validity of our imaging markers in the clinical setting. Lastly, I just want to mention that I really talked about single echo DSC during my talk, but there are also looming on the horizon multi-echo techniques that might provide simultaneous assessment of multiple perfusion markers. This is a slide lent to me from Chad Quarles, and it demonstrates multi-parametric DSC plus DCE using a single bolus injection. And techniques like this can provide simultaneous acquisition of CBV, vessel size, vessel architecture, permeability, and cytoarchitecture, and might be useful in the future in clinical trials and in our daily clinical practice. And this would require the dissemination of these advanced pulse sequences to multiple sites and multi-site validation. So in summary, I've reviewed DSC fundamentals and the contrast mechanism. We talked about the issue of contrast agent extravasation and correction. Provided some evidence supporting the best acquisition protocols for clinical DSC, and summarized where we stand on our thinking about a current consensus panel DSC protocol recommendation, and provided some ongoing trials working towards its validation and broader acceptance. And I thank you for your attention.